All right, I think we're ready to get started here. So good morning or afternoon, depending on where you're located. Just want to make sure, do kind of a check here to make sure everybody can hear me. If you wouldn't mind typing into the chat box or the Q&A box, whether or not you can hear, that would be great. All right, perfect. Thank you so much. So first, I'd like to thank the PECA team for the opportunity for today's webinar session and to thank all of you for joining us. To get us started, I need to review some webinar logistics. So first, everyone is muted to keep background noise in check. Second is we will have a question and answer session at the end. So please feel free to enter any questions or comments as we go through the content into the Q&A box or into the chat box. Anything that we can't dig into, we will follow up with you on afterwards. And lastly, this session is being recorded and we will get this to the PECA team to post as soon as we can. So today's topic is no is not always their final answer. Otherwise fondly known to us as it's us against them. Dave, would you mind advancing the slide? Perfect, thank you. We're going to touch on the main topics related to dealing with denials. We'll try to shed some light on the appeals process, when to appeal and how to appeal. We'll review common denial reasons with a focus on ones that are worth chasing. We'll cover the practicality around dealing with payer reps. We'll suggest some best practices or process on working denials, with all of this centered around not taking no for an answer. Okay, so to introduce us all, my name is Christine Schneider. I'm the VP of Operations and co-founder of RevCycle Partners. I am also joined by Amanda Kissinger and Sarah Gray from our billing teams. Ladies, I'll let you both introduce yourselves and give everyone a little bit of information on your background. So Amanda, we'll start with you.
Hi, I'm Amanda Kissinger. I have been with RevCycle Partners for about 7 years. I have almost 15 years of experience in billing. I did start out in dental before moving to optometry. Most recent experience, probably the past 11 years, has been in optometry.
Perfect. Sarah?
Hi, everyone. My name is Sarah Gray, and my background comes mainly in the optometry world. Prior to RevCycle Partners, I did billing in an optometry office for 7 years, and I've currently been with RevCycle Partners for 3 years now, working with the billing side as well as the aging.
Wonderful. Thank you. So the claims process. We all get caught up inside of it. You know, we get our claim rejections, we're refiling claims, we're getting claim denials, we're filing claim corrections, we're filing appeals. And it's really a waiting game, waiting and waiting and more waiting, whether it's on the phone to talk to a representative, whether it's waiting for a message to be returned, or waiting for the reprocessing of a claim or a decision on an appeal. It's a frustrating experience a lot of times. So we all know the process eats up a lot of our time, and I think it eats up mostly our patience. So to ease into the topic and to talk at a high level before digging into the weeds, Amanda, going to start with you, throwing a question out here. So talk to us about your philosophy in respect to dealing with payers. How do you see the payer in the story?
You know, I think it's important to know and have the mindset that payers are in the business of denials. You should all know this from dealing even with your personal health insurance or auto or home insurance. Insurance, they definitely want to fight for, getting around not being able to pay that if they have that opportunity. So understanding that they are in the business of denials and they're not willing to just give money out that they don't have to is going to be important to have that mindset.
Sarah, what's your take? What's your philosophy on them?
I feel like the reps that we're talking to at the insurance company, they're more like the middleman. They're usually always following some type of script, or they have some type of timeline that they have to get their calls done. And it's really taking that time to deal with those reps and try and drive them outside of the script to get the information you really need.
Very, very true. So why would an insurance customer service rep not be helpful? I mean, aren't they supposed to be the experts in supporting benefits, claims, all of that?
Honestly, they're more of in a position of power. A lot of the billers that you deal with the insurance companies, they don't know as much as we do all in this webinar. They'll normally tell you, we're not coders. I can't tell you how to bill it, or try and skirt around the issues that you have.
Also, I think, some of these reps can be pretty green. New hires, they may not have much experience actually dealing at the practice level on our side of things of processing the claims and following the guidelines. They may simply be trained by the script that they go by and not actually having that in practice experience.
So do you have strategies that you rely on to help how you approach a payer rep?
Yeah, I think that you should maintain a level of professionalism, be prepared and specific. So if you're troubleshooting a denial related to the coding, have your coding guidelines readily available, cross-reference and make sure that if you can pick up on what that denial may be, you could then drill it down to the next level of that question.
And I think another big thing is, once again, trying to drive them off of that script. Come prepared with particular questions that are specific to the claim, to medical policies, to the way something processed. And then that way that can kind of drive the conversation away from what they just might be, in a better word, programmed to tell you when they're on a call with you.
Okay. So if we dig in a little bit deeper, are there common scenarios in which you feel billers may give up too easily, where they accept no as the answer when they should really chase after that claim?
I think that some billers just don't want to spend the time. They figure they're going to cut their losses, without going through that appeal process or investigating that denial more, knowing that it may be more time involved, depending on the cost of that claim and what the possible reimbursement is.
And I think other things that might be more of a common scenario you see might be something to do with prior authorizations or referrals. If it's something that you didn't have prior to the visit or just wasn't included on the claim, a lot of the times those are easily able to be appealed and won over time.
We also see, denials that's related to coding. It may require just minor modifications. Maybe your diagnosis code is an unspecified condition and they're just looking for it to be a little bit more specific. It's a pretty easy correction to get that claim turned around and processed. It's worth looking into the coding and how everything is set up, why it's denying, and what opportunities you have to correct that and reprocess.
Okay. Any other examples come to mind?
Just off the top of my head, I know that I've recently dealt with a situation that was pretty vague, dealing with a medical CPT and a medical diagnosis. The payer rep was giving me a very generic response. I think that you can also see new patient versus established patient coding, where you may get denials for that. You may have a diagnosis that's showing for both eyes, and the payer may want it actually reflected as a bilateral. So lots of different variables on what could cause a denial.
So when you set aside time in your day to chase either denied claims or to work through aging, how do you approach it, and what homework do you do ahead of time?
I would say definitely go back to your remit before anything. Look back at that explanation of payment, see what you can see on the denial reasons or remark codes. So you've got a grounds to start your mission on finding out why it actually did deny. Be prepared with if it's something to deal with CMS guidelines or a specific payer policy. Try and do as much research on your own as you can to see if you can figure this out before having to reach out to the insurance companies.
Time management is also an issue for most of us, especially taking the time to do the research, gathering the data, cross-referencing information, making those payer phone calls. That is definitely time involved. A lot of us are kind of keeping up with the day-to-day activities, and time management is something that you should definitely make the time for. Some best practices are suggestions would be on slower days. We do see sometimes in the practice that certain days may be a little slower. Maybe you don't have a doctor in the office that day. That is a great day to block off a good hour or two of that day to handle nothing but denials and appeals and those payer phone calls. And that just creates a good workflow in the practice.
To add on to that, for myself personally, when I do have an account that I'm working, I like to set a goal for myself of 5 to 10 claims per day to look at in aging, whether I'm processing payments and, just taking a quick peek to see, okay, are there older dates of service here that I'm, seeing that if I'm processing dates that are, more current, probably want to check on that and be a little bit more proactive.
Absolutely.
All right. So if you do have to contact the payer, what evidence do you want to have ready for that specific claim? I know, Sarah, too, you've talked about like getting them off script. So what are some questions or scenarios that we could, have ready for that specific claim when we're calling?
I would definitely say, first and foremost, having that remit accessible, because you'll have all of the pertinent information that you'll need. You'll have your claim numbers, you'll have the information of when it processed, your denial reasons, and then you'll just have to have that little bit of a backup of in your EHR and looking at, the patient's information or their birth date, the practice information such as tax IDs or NPIs, because of course they always end up asking that as like the preliminary set of questions before you even can get into what's actually going on with the claim.
Yeah, and I think if you were dealing with coding types of denials specifically, not only having all of the patient's information, practice information, a copy of that claim, but also having any types of coding guidelines that you can reference to as well, such as your local coverage determination articles, your payer provider manual that may have specific guidelines to adhere to regarding that coding. Anything that you could use to segment into a more detailed question with the payer to get more information related to what the denial actually is.
Okay. So what reasons for delays in dealing with things like timely filing have you found to be acceptable, or have you been successful with in overturning a claim denial?
I think a big one, and it surprisingly is still one that a lot of insurance companies will follow, is COVID is a reason. Your regulations in your state or how you've had to change things in your practices, the insurance companies will look at that. And I mean, they've been going through it as well with possible staff shortages and everything. So they see why time might have taken a little bit away from the claim getting processed when it should have, or, in that same grouping, if you've had staff turnover even.
So rather than maybe waiting on the phone and dealing with a representative directly, what other tools are available to billers to help them figure out denials, or maybe do some appeals, or just have other ways to be able to approach aging?
There are, multi-payer portals such as Availity. I personally like the Availity option. It gives you for most payers, will give you the opportunity to do an online chat with the payer. To just kind of, if you have a long hold time, you can kind of bypass that, do an online chat to get the answer that you're needing. Also, individual, payer portals themselves may have a contact us area where you could email somebody instead of sitting on hold for multiple hours. Sarah, was there any others that I'm not thinking of other tools?
I would definitely say if there's any type of special requirements, say on the payer portals, like if they give you the options of processing appeals through the portals, if they give you the options to dig into the policies for the medical policies, then definitely going that electronic route, if you have that option, will save the time for sure.
We're also seeing that there are some payers that are kind of moving to the electronic side of things anyways. There are some payers that you can't get to a live person and they kind of direct you to using their contact options through whatever portal they're using.
Good to know. So after working with a customer rep and following their direction and still not getting a claim paid, when do you decide to appeal, and is appealing really worth it?
I think it's always worth the initiative of an appeal, especially if you have supporting information. If you know that you have submitted that claim timely, but there was a lapse of the handoff between the clearinghouse and the payer, or whatever that reasoning may be, definitely prepare your supporting information and do that appeal process. It's worth that attempt. If you are looking at a denial that is several years old and you for some reason do not know why it took this long to get paid, you really don't have supporting information, that's going to be a personal decision and may come down to time and effort versus the return. If you're going to invest an hour or more preparing the data and the appeal process, but it's for a $25 claim, it may not give you the type of return for what you're spending the time on. But my big rule is if you have a leg to stand on, any supportive information, it's always worth the attempt.
So what's the process for appeals? What time frame should you work within for those?
I think the big one with the processes for the appeals and their timeframes is make sure you know what timeframes you're working with in specific insurances, because a lot of the times it could be a 90-day, 120-day, or even in some cases like Medicare, 365 days, depending upon when that initial claim was submitted. They do have rules of how long after it has processed of when you can actually submit that appeal. So make sure you know that kind of information, and knowing that, make sure you kind of have things lined up if you can, or prepped in the office, something along the lines of if it's a common denial that you see, try and have a template set up for a letter to where you might just have to change the insurance information or claim information. That way you will save yourself time knowing that you have that already ready to go, and you just have to get all your information together to submit to the insurance.
There are a few payers that will require a particular form to be filled out for their appeal process rather than just a generic letter. So be aware of your payers that you're dealing with. Look to see if they have any specific forms that they would require to use, and use that form instead of just doing a generic.
Okay. Do you have any tips to offer to minimize denials going forward?
I would say a big one is when it comes to your plans, when they require a prior author referral, make sure you're getting those prior to the visit, because a lot of the insurance companies in some cases don't allow you to get backdated authorizations. And because you didn't have it prior to the visit, of course, it's going to deny, and you're going to have to go through that process of fighting to get that to reprocess.
Mhm.
being able to learn from the denials that you're seeing. A lot of offices will see that they tend to struggle on certain areas versus others. Those services or the payer that you're dealing with that you see the most common denials, what are those? What's causing that denial? What is it that you can implement in the practice setting to make doctor or front desk staff or whoever is in charge of what might be leading into that denial, educate them so that they can learn from that and try to prevent those mistakes going forward.
Great. So let's end this part of the discussion on a high note. Do either of you have some examples you'd like to share of some wins?
I know, Amanda, I know you have one that you always tell me about. That's a
I
really
have
good
one
one.
that I definitely pride myself on. I've got a lot of wins, but one in particular, I think dealing with United Healthcare, they have a 90-day timely filing limit. And I was able to appeal a claim from a 2014 date. I got paid on that in 2016, and they paid me interest.
I think one of the good ones that I've had recently, I know normally Medicare, when you're past your 365 days for the timely filing, they pretty much say right on their remit, you can't appeal this decision. I worked back through things with redeterminations and reopenings to actually deal with reps, everything, and got something that was a Medicare timely filing reprocessed and paid. Granted, it was a more recent claim, not as old as Amanda's, but shockingly got Medicare to overturn something.
Yeah,
That is a big
that's a win.
Big one at that, yes. All right, so now is the time to get questions in or comments in. And while I give you some time to do that, I'd like to mention just one of our RevCycle services. Most people know us for ongoing services where we take on the full claim cycle responsibility for medical and or vision claims, but we also offer one-time custom AR cleanup projects. And these projects don't require ongoing services or anything else to be additive to it. So whatever the reason for AR falling behind, whether it's staff turnover, whether it's just time, whether it's lack of experience, if your AR is stacked up, you could give it to us to tackle. We do provide complimentary assessment of the AR, and based on the quantity of claims, the age of claims, payer mix, and so on, we'll provide back a custom quote to work the project. Sarah, can you give just some insight into what a standalone AR project looks like from our perspective, from an operations perspective, since you actually handle a lot of those?
What it is we'll have that listing of all the claims that are within the time frames and what you're wanting to be worked, broken down by payer, and we go through and any accesses that we can use from payer portals, the insurance company websites, any clearinghouses you might have, we dig in as much as we can to find out if a claim's been processed, if it's been denied, if it hasn't even been submitted to begin with, what's going on with it. And we take that time of calling the insurance, finding out if we can appeal things, posting payments if it's something that just was missed in posting. There's a lot of different elements thrown into the mix to make sure that those claims do get taken care of and then they're taken off of your AR.
Okay. Thank you for that. So on to the questions. So we do have a question here. So who is ultimately responsible for getting the referral? Is it the patient or is it the provider? And I can jump in on this answer, ladies, of how I perceive this. Ultimately the contract is between the patient and the insurance company, right? And, the ownness, I think, of knowing and understanding the benefits truly does belong to the patient. I think in today's day and age, though, I think patients rely on the provider to know what their benefits are, to know what they're eligible for, and to know the ins and outs of what's needed in order for that visit to get covered underneath the insurance. So I kind of think of it, as a dual answer. However, ultimately the responsibility is, I think, on the patient. There are sometimes though where you will get a denial where the insurance company says, no, the provider's responsible, that you get that CO write off because the provider didn't get that required authorization or referral because that's how the plan is set up. So, being aware, I think, of what the plans mandate and where they place responsibility is also key. Not sure, Amanda, Sarah, if you agree, disagree, have anything
That is
where you want
exactly what I was going to echo, Christine.
Okay. So we have a question here. Is anyone familiar with Primera Insurance? They don't have a live person to speak to in regards to denied claims. So I think maybe the question is, how do you work with payers like that?
We kind of spoke on that earlier. There, as we're seeing so many automation in the industry and things going to more electronic opportunities, we're also seeing that on the payer side. Of course, most of them do have a live rep. Sometimes it's just very difficult to get through to them, or you're, rerouted to multiple areas before you can finally get in contact with somebody. I would definitely say if you're having any pain points working with your payer, definitely reach out to the provider relations rep. It is kind of their job to make sure that they can support you and equip you with the right resources that you need to partner with them. However, we are familiar with the payer, and we will also talk about the opportunity of using that payer portal. I believe you may be using the One Health port. They do have opportunities of doing live chats with the payer. So try that route. If you do not have that access, unable to get any traction, try reaching out to a provider relations rep.
One thing I found too, back when I owned more accounts, is how you're set up inside of these payer portals, depending on who in the office has set it up. You might want to just double check even your access. Do you have access to the chat and, being able to send secure messages? Is your payer just set up to be able to check eligibility and things like that? So that's also another avenue. So what if a claim denied for timely filing a year or more after timely filing limits? What would you do?
Like I had mentioned, it's always worth that appeal attempt. If you don't try, then you may never, get any positive outcomes if you have that supporting information. So if this is a situation in which you would need to do the research, see what supporting information you have. Do you have a timestamp that you did get it submitted in that initial time frame? Are you still within the time limits for filing an appeal process? And then decide whether you feel that the time invested preparing all of this information based on your initial research is worth the outcome of the potential return.
Okay. You talked about, having homework done or having things ready for calling an insurance. What information do you consider what information would you consider sending for an appeal? Sorry, I was trying to read the question and interpret what they were asking. So yeah, so basically what is considered supporting information?
I would say with the supporting information would be your claim submission history from your clearinghouse, or even the claim submission history in your EHR, insurance information from the patient if it was originally incorrect or submitted to another insurance initially, a letter with good reason or good explanation for your appeal. I mean, it could be something along the lines of issues with technology, staffing changes, and also making sure that you have possibly that specific form for an appeal if the insurance company does require those along with your supporting documentation.
Okay. And I think this looks like this might be the last question. What if I have proof of timely but still received denial after completing the appeal?
If you do have that supporting evidence that you prepared with that appeal letter, and the payer has not overturned the outcome of that claim, first question the time frame in which you have the right to appeal. If you're still within that guideline or the time frame, you should proceed with the second level appeal. Possibly even involve that provider relations rep for any additional assistance if you're not getting that positive outcome. But definitely keep pursuing it when you do have that supportive proof and evidence to fight with.
All right. I don't see any other questions in either the chat box or in the Q&A side. So I think that's a wrap. Thank you all for your time, and to Amanda and Sarah for joining the session and having the discussion. If anybody is interested in a complimentary assessment, or if you have other thoughts, questions, requests, or anything like that, our contact information is up on the screen oh, no, it's not up on the screen. Dave, can you advance? Whoops. Yeah, and certainly reach out to us at any time here, and we'll get back to you. Other than that, I will say,
I think it looked like we had one more question pop
Oh.
up in the chat.
Great, go ahead.
Let's see.
Oh, yeah. So how do you handle denials when the payer is very vague?
That is, unfortunately, the common answer you're going to get is those very vague questions. And the goal here is to try to drive those payers off of those vague questions by being prepared with those second level questions. So if you are getting a denial that your diagnosis is not supportive of your CPT, have that diagnosis, local coverage determination list pulled up to make sure it is supportive of that CPT. When you get in the conversation with the payer, go into the details with them. Can you explain to me why X, Y, and Z diagnosis does not work with this service? Is there an exclusion to the patient's policy? Is there any limitations to this service? Ask those next level detailed questions, driving them away from those vague questions so that they don't have a script prepared to answer those. They're going to have to come out of that shell a little bit. And if they don't, and they're unfamiliar with how to respond to that, then they may have to reach out to even their supervisors for additional support.
Okay. Dave, can you go to the last or to the next screen to put our contact information up there, please? All right, perfect. Sorry about the delays. This is our first time using Zoom in this format. So we have somebody driving the slides and of course us trying to talk through the content here. So I don't see anything else coming in or looking like it's being typed. So try to say that's a wrap again, I guess. Hope everybody has a great day otherwise. And thanks for joining us.